Greetings, dear learners. In the last class, we were learning the management of poisoning. In that, we discussed the management of circulation and the depression of CNS under immediate resuscitative measures. Till now, we learned what are the broad guidelines on the management of poisoning. That is, immediate resuscitative measures, removal of unabsorbed poisons from the body, removal of absorbed poison from the body, administration of antidotes, symptomatic treatment, adequate follow-up, and the nursing and psychiatric care. We will be dealing each of the topic one by one. Under the immediate resuscitative measure, we learned that patients of poisoning shall be removed from the poisonous surroundings and ABCD of resuscitation shall be performed. Under the ABCD of the resuscitation, we learned up till now airway, breathing, circulation and depression of the CNS. To manage the circulation, we must first correct the acid-base balance if present. Elevate the foot end of the bed, insert a large bore peripheral IV line, administer a fluid challenge of 200 ml of saline, observe for improvement in blood pressure over the 10 minutes, repeat the fluid bolus if the BP fails to normalize and assess for the signs of fluid overload. Short-term low-dose vasopressors such as dopamine and norepinephrine may be given. Hemodynamic monitoring should be considered in those patients who don't respond. And then ECG and cardiac rhythm shall be noted and managed accordingly. So, in the last class, we learned all the ECG changes seen on the electrocardiogram and their respective management. Then we learned depression of the CNS management. Management of the CNS depression, we shall rule out the hysterical coma, then coma cocktail shall be administered, that is the dextrose, thymine and naloxone. They are seen to be effective in cases of unknown poisoning along with 100% oxygen ventilation by the mask. Of late, physicians are increasingly resorting to extracorporeal membrane oxygenation in the managing profound cardiorespiratory failure from many causes including poisoning. So, as we discussed that we will discuss extracorporeal membrane oxygenation, that is ECMO today, and step E of the resuscitation, that is other aspects of the management. Extracorporeal membrane oxygenation is also known as extracorporeal life support, ECLS, that is an extracorporeal technique of providing prolonged cardiac and respiratory support to the person whose heart and lungs are unable to provide an adequate amount of gas exchange or perfusion to sustain the life. Extracorporeal membrane oxygenation works by removing blood from the person's body and artificially removing the carbon dioxide and oxygenating red blood cells. Generally, it is used either post-cardiopulmonary bypass or in the late stage treatment of the person with a profound heart or lung failure. Although it is now seeing use as a treatment for the cardiac arrest, allowing for the treatment of the underlying causes of the arrest while circulation and oxygenation are supported. Indications for the ECMO are hypoxic respiratory failure, hypercapnic respiratory failure with arterial pH less than 7.20, refractory cardiogenic shock, cardiac arrests, failure to wean from the cardiopulmonary bypass after cardiac surgery, as a bridge to either heart transplantation or placement of a ventricular assist device, as a bridge of lung transplantation. These are all indication for the extracorporeal membrane oxygenation. Extracorporeal membrane oxygenation are of two main types. One is the veno-arterial membrane oxygenation and the veno-venous VV ECMO. In both the modalities, blood is drained from the venous system, is oxygenated outside. As you can see in this picture, that blood is being taken out from this iliac femoral vein, and then it is passed through this machine, that is outside machine, that has got oxygenation. Outside oxygenation is done, and the pump is there which will pump it out again back to the body. So when the taking in outflow is through the venous channel and inflow is through the arterial channel, then it is the arteriovenous ECMO. When it is the outflow is from the venous channel and inflow is again from the venous channel, then it is the veno-venal ECMO. In veno-arterial ECMO, this blood is returned to the arterial system, and in veno-venal ECMO, the blood is returned to the venous system. In veno-venous ECMO, no cardiac support is provided. Veno-arterial ECMO, a venous cannula is usually placed in the right common femoral vein for the extraction, and an arterial cannula is placed into the right femoral artery for infusion. The tip of the femoral venous cannula should be maintained near the junction of the inferior vena cava and the right atrium, while the tip of femoral arterial cannula is maintained in the iliac artery. In adults, assessing the femoral artery is preferred because the insertion is simpler. Central veno-arterial ECMO may be used if cardiopulmonary bypass has already been established with cannula in the right atrium and ascending aorta. In veno-venous ECMO, cannulae are usually placed in the right common femoral vein, as you can see in the picture, for the drainage, and the right internal jugular vein for the infusion. That this infusion is done under the right internal jugular vein, and the effusion is from the right common femoral vein. Alternatively, a dual lumen catheter is inserted into the right internal jugular vein, draining blood from the superior and inferior vena cava and returning it to the right atrium. Veno-venal ECMO is typically used for the respiratory failure, while veno-arterial ECMO is used for the cardiac failure. This is the important point to note regarding the extracorporeal membrane oxygenation. So with this, we have covered A, B, C and D of the resuscitation. Now we will cover the E, that is evaluation of the patient. Evaluation of the patient is not an immediate resuscitative measures, yet it should be done as soon as the patient is stabilized. We shall go now for the full head to toe examination and all the basic clinical examination, including detailed systemic examination. Breath sound, auscultate and re-auscultate, particularly after the IV fluid has been given. It helps to diagnose pulmonary edema and acute lung injury and the aspiration pneumonias. If crackles and rhonchi are present, especially if coupled with abnormal breath odor, such as seen in hydrocarbons, it may point to pulmonary etiology rather than cardiac etiology. This is important because administration of cardiac medications may be dangerous in case of pulmonary etiology. We must listen heart sounds like murmurs and dysrhythmias. Murmurs in an injection drug abuser, especially when accompanied by fever, indicates bacterial endocarditis, whereas dysrhythmia suggests overdose of the cardiac poisons like digoxin, beta-adrenergic antagonists. Abdominal examination shall be done properly. Enlarged liver are suggestive of hepatotoxic poison and chronic alcoholism. Bowel sounds shall be used to diagnose or exclude cholinergic or anticholinergic toxicity. Bowel sounds will be seen in case of the cholinergic toxicity, whereas there will be dryness in anticholinergic toxicity. It helps to decide if the purgatives will be useful or not. Lack of bowel sounds points to the anticholinergic poisoning, and purgatives may not be very useful. Whereas presence of bowel sound is suggestive of cholinergic poisoning and purgatives may be useful. Then we shall do the examination of the extremities. E may also stand for the elimination of poison, ECG and expose. So, in the A, B, C, D, E of the resuscitative measures, all this may be the meaning of E. Additionally, in those patients poisoned with some toxic substances, patients where there appears to be no crisis, a detailed and thorough clinical examination should be made with a special reference to the detection and treatment of any of following abnormalities. That may be hypothermia, hyperthermia, rhabdomyolysis, acid-base disorders, convulsions, agitation, movement disorders, electrolyte disturbances. Coming to the hypothermia. Depending upon the temperature of the body, different manifestations may be present in the patients. In the CNS manifestation, at the mild hypothermia, there will be amnesia, dysarthria, impaired judgment. Whereas the moderate hypothermia, there may be drowsiness, mydriasis, paradoxical undressing, hallucinations. Coma and the loss of the ocular reflexes may be seen in case of severe hypothermia, that is temperature below 82.4 degree Fahrenheit. Serious features in case of mild hypothermia may be tachycardia progressing to bradycardia. In the mild hypothermia, the patient will present with the tachypnea followed by decrease in the minute volume and bronchospasm. Further, cold diuresis and shivering will be seen in the mild hypothermia. And in musculature, increased muscle tone followed by fatigue and anoxia will be seen in musculoskeletal system. Whereas in the CVS, moderate poisoning will present with atrial and ventricular arrhythmias, lowered blood pressure, and J-wave on ECG that we discussed in the last class, that is also called Osborne waves. Then the patient may present with the hypoventilation, increased renal blood flow, hyporeflexia and rigidity. Severe hypothermia, the patient already we discussed in the CNS that the patient will be in coma, loss of ocular reflexes. Then the severe hypotension, bradycardia, asystole and raised blood pressure may point to severe hypothermia. Pulmonary edema and apnea may be there. Decreased renal blood flow, oliguria, poikilothermia are suggestive of severe hypothermia. No motion and peripheral areflexia will be suggestive of severe hypothermia. Then it is essential to use low reading rectal temperature to monitor the exact temperature of the body. Electronic thermometers with flexible probes are best, which can also be used to record the esophageal and bladder temperatures. Drug producing hypothermias are alcohols, antidepressants, barbiturates, benzodiazepines, carbon monoxides, hypoglycemics, opiates, phenothiazines, sedatives and hypnotics. Treatment of hypothermia includes rewarming the patient For mild cases, a warm water bath is sufficient until the cold temperature rises to 92 degrees Fahrenheit, when the patient is placed in a bed with warm blankets. The rate of rewarming should not exceed 5 degrees Fahrenheit per hour. Heating the inspired air is also recommended by some as very effective in raising the core body temperature. Others advocate gastric lavage with warm fluid or peritoneal lavage with warm disilate. In addition, it may be necessary to correct other associated anomalies such as hypotension, hypoventilation, acidosis, and hypokalemia. Then looking for the hyperthermia. Oral temperature above 102 degrees Fahrenheit is referred to as hypothermia. If it exceeds 106 degrees Fahrenheit, which is very rare, there is imminent danger of encephalopathy. In few individuals, there is genetic susceptibility to hypothermia, especially on exposure to the skeletal muscle relaxants, inhalational anesthetics, and even local anesthetic malignant hypothermia. This should be distinguished from the neuroleptic malignant syndrome, which is also characterized by high fever apart from other neurological signs. But the neurological malignant syndrome, that is neuroleptic malignant syndrome, is the result of adverse reaction to the antipsychotic or neuroleptic drugs, and it doesn't have any genetic basis. Agents producing hypothermia are classified based on the mechanism of action by which they are producing hypothermia. Like the drugs that produce hyperthermia by muscular hyperactivity are the amphetamines, antidepressants, cocaine, MAO inhibitors, phencyclidine, strychnine, and withdrawal of opiates and alcohols. Increased metabolic rate are the reason in cases of dinitrophenol, salicylates, thyroid hormones. And impaired thermoregulations are produced in case of anticholinergics, antihistaminics, antipsychotics, ephedrine, phenylpropylamine, phenothiazines. Now coming to the management of hypothermia. Mild to moderate hypothermia may respond to the conventional cooling measures. When rising body temperature exceeds 39 degrees Celsius, core temperature monitoring should be considered, that is using rectal probe, and urgent cooling measures should be employed according to local protocols. Sedation should be employed where it can be safely performed. That should be done using diazepam in a dose 10 to 20 mg in case of adults and 0.25 mg per kg in children. Cooling methods may include ice baths that may achieve rapid cooling but cautiously used in elderly and comorbid patients. Internal or invasive measures are the cold fluid lavage, gastric lavage, bladder lavage or peritoneal lavage, intravascular cooling techniques, ice packs applied to the groin and axilla, mist and fan techniques, external cooling devices may also be used. Dantrolene may be considered where there is the muscular hyperactivity, that is given in the dose of 1 mg per kg IV to a maximum 10 mg per kg. In patients with hypyrexia, monitor renal function and creatinine kinase activity. Ensure adequate hydration and monitor urine output carefully. Severe hypothermia carries a high risk of mortality, so aggressive intervention is recommended. Rapid sequence intubation with paralysis is usually warranted when the temperature is rising rapidly and not controlled by the other measures, or if the temperature exceeds 41 degrees Celsius. Rapid sequence intubation shall be known by us that it is a phenomenon where the airway management technique that produces the inducing immediate unresponsiveness and muscle relaxation and is the fastest and most effective means of controlling the emergency airway. That is a technique that is learned by the anesthetist usually, where the normally what we are doing, we are giving the endotracheal tube or tracheostomy, but this endotracheal tube may be easily applied by the giving the anesthetic effect, muscle relaxation, so that it is not obstructing for application of these endotracheal tubes and airway management methods. This is called rapid sequence intubation. If hyperkalemia is largely, avoid succinylcholine. Ongoing neuromuscular paralysis and sedations with benzodiazepine is recommended in addition to the cooling measures as local protocol. Further, the management and the details about the rhabdomyolysis. Rhabdomyolysis, that is the breakage rhabdomyolysis, that is breakage of the muscle, lysis of the muscles, is a condition in which the damaged skeletal striated muscles breaks down rapidly. It is quite commonly associated with toxicological situations with hyperthermia, convulsions, or some kind of envenomations. Envenomation, as you will be knowing, that the musculotoxic snakes are there. Breakdown products of damaged muscle cells are released into the bloodstream. Some of these, such as myoglobin, are harmful to the kidneys and may lead to the renal failure. The symptoms of rhabdomyolysis depends on its severity and whether the renal failure develops. Milder forms may not cause any muscle symptoms, and the diagnosis is based on abnormal blood tests in the context of other problems. More severe rhabdomyolysis is characterized by muscle pain, tenderness, weakness, and swelling of the affected muscle. Release of the components of the muscle tissues into the bloodstream causes electrolyte disturbances, which can lead to nausea, vomiting, confusion, coma, or abnormal heart rate and the rhythms. Urine may be dark in color, often described as tea-colored or cola-colored due to presence of myoglobin. Damage to the kidney may give rise to decreased or absent urine production, usually 12 to 24 hours after the initial muscle damage. Many drugs increase the risk of rhabdomyolysis. The most important ones are statins and fibrates. That is, the serivastatin was withdrawn in 2001 for the numerous reports of rhabdomyolysis. Antipsychotic medications may cause neuroleptic malignant syndrome, which can cause severe muscle rigidity and rhabdomyolysis and hyperpyrexia. Neuromuscular blocking agents used in the anesthesia may result in malignant hypothermia, also associated with the rhabdomyolysis. Drugs that causes serotonin syndrome such as SSRI, drugs that interfere with the potassium levels such as diuretics, poisons linked to the rhabdomyolysis are the heavy metals and venoms from the insects or the snakes. Drug of abuse like alcohol, amphetamines, cocaine, heroin, ketamine, lysergic acetaldehyde, MDMA, that is ecstasy, all can be responsible for the rhabdomyolysis. Then the management and diagnosis of the rhabdomyolysis. The most reliable test in the diagnosis of the rhabdomyolysis is the level of the creatinine kinase in the blood. This enzyme is released by the damaged muscle, and the levels above the 5 times the upper limit of the normal indicates the rhabdomyolysis. Myoglobin has a short life and is therefore less useful as a diagnostic test in the later stages. Its detection in the blood or urine is associated with higher risk of the kidney impairment. Elevated concentration of lactate dehydrogenase may be detected. Other markers of the muscle damage such as aldolase, troponin, carbonic anhydrase type 3, fatty acid binding proteins are mainly used in chronic muscle diseases. Electrocardiograph may show whether the elevated potassium levels are affecting the conduction system of the heart as suggested by the presence of T-wave changes or broadening of the QRS complex that we already saw in the last class. Treatment of the rhabdomyolysis are the volume replacement. Give volume replacement as soon as possible and consider the need for the urine alkalinization. In an adult, for the alkalinization of urine, give 225 millimole of 8.4% sodium bicarbonate, and in child, dose is 3 to 5 millimole per kg over 1 hour to increase the urine pH to greater than 7.5. Further dosage of bicarbonate will be required to maintain the pH greater than 7.5. Hemofiltration can effectively remove the myoglobin from the circulation. Hemodiafiltration combined with urine alkalinization is more effective than urine alkalinization alone. We will be learning in the management of the poisoning where the removal of unabsorbed poison, we will be managing it through the alkalinization of urine. There we will learn how this urine alkalinization helps in the removal of the myoglobin.